I'm your host, Dale Sherbeck, and welcome to the HQ podcast. For those tuning in for the first time, the HQ is a podcast serial produced by CHA Learning and is your trusted source for important conversations on healthcare issues and topics from those that are leading and impacting the health system. Together, we'll explore these topics as we continue to learn together. CHA Learning is the professional development division of Healthcare Can and is uniquely Canada's only national fully online learning provider serving all of healthcare. So please check out more about our learning programs and services after this episode and discover how we collaborate with health leaders and organizations like those we feature on the HQ to empower healthcare professionals with the knowledge, skills, and relationships to impact health system improvement. Thank you, listeners, for joining me today for what may be, for many of us, a difficult but critically important conversation to have or listen to: suicide. As healthcare professionals, whether a nurse, physician, or other health professional, you encounter diverse groups of people every day. People with a huge array of backgrounds and histories. You're meeting people at different points in their lives, people presenting with all manner of health concerns and needs, and you're speaking with people who are often at their most vulnerable, often worried, anxious, or scared. You will have a multitude of conversations with these different people as you seek to understand them and their needs. Many conversations will be hard to predict and will take you in directions you don't expect. One topic of conversation, however, will permeate across every population, one which can be the most difficult topic in conversation any of us might ever have, and that is suicide. So why is that? Why is it so hard? So hard that many health professionals might even avoid it. Avoid asking a question that may save someone from harm. At the heart of this is the issue of stigma that too often continues to cling to this topic, which is why we're all talking about it today on the HQ. There are many questions circling this topic in healthcare, including where do you start? What do you say? How personal should you become? How vulnerable can and should you be yourself? How do you create a safe space? What if you say the wrong thing? Perhaps hardest of all, what happens if a person says, yes, I am thinking of suicide? What is your shared responsibility in those moments to both address suicide and instill hope in patients, residents, and clients? All of this and more is the purpose of today's conversation, which is itself inspired by a free course that CHA Learning partnered with the Mental Health Commission of Canada to develop and launch recently, aptly called Talking About Suicide, Empowering Healthcare Providers and Instilling Hope in Clients. So please check out the show notes to learn more about this at the end. But for now, and to help us have this conversation, I'm joined by three amazing people, each personally and professionally committed to this topic. Anita David has transformed her lived and living experience into a career in mental health and substance use, health advocacy, engagement, research, and education. Anita is a lived experience strategic advisor at BC Mental Health and co-chair of the Hallway Group at the Mental Health Commission of Canada. She recently received a King Charles III Coronation Medal for advancing mental health advocacy, education, and research, and fostering strong networks among patients, families, and health organizations. Next, I'm pleased to introduce Dr. Cheryl Pollard, who is a professor in the Faculty of Nursing at the University of Regina and a recognized thought leader in healthcare education, innovation, and leadership. Her work centers on promoting mental health and well-being, especially for individuals living with mental illness and their caregivers. Dr. Pollard's research explores the power of compassionate relationships within learning environments and their impact on education. She was inducted as a Fellow of the National League for Nursing's Academy of Nursing Education in recognition of her enduring contributions for nursing education. And last but not least, I'm joined by Dr. Alison Crawford, the Chief Medical Officer for 988, the Suicide Crisis Helpline. She is also a professor in the Departments of Psychiatry and the Dalla Lana School of Public Health at the University of Toronto, and a psychiatrist and senior scientist at the Centre for Addiction and Mental Health. A key focus of Alison's work is improving access and equity in mental health care, especially to rural and underserved regions. She has also overseen psychiatry services in Nunavut since 2010, and Alison has a PhD in English literature and brings the arts and health research through much of her work. So hi, Anita, Cheryl, and Alison, and welcome to the HQ.
Hi, Dale. Thanks for having us. Yeah, thank you.
Thanks so much. I'm looking forward to this conversation.
Yes, and many thanks to all of you. I am looking forward to this conversation too, and for joining me here to have this. It is a very difficult and important conversation. So, while I've shared a little bit in terms by way of an introduction for each of you, I'm wondering if we can maybe begin in your own words. What is drawing you to this work and what it means to you? So, maybe we can start with you, Anita.
Sure. Thanks, Dale. Um, so I'll just start out by saying that I've lived with mental illness and suicide ideation for as long as I can remember, like before I even had words to speak what they were and what it was and what it meant. One of my lowest points is when my ideation turned into action. But I got really lucky that when my doctor intervened and instead of ending my life, I spent 6 weeks in the hospital. I also experienced loss of loved ones and acquaintances to suicide. And those experiences have marked me deeply. For me, suicide comes down to ending the enduring pain that destroys any glimmer of hope. Attempts and or completion of suicide. The stats, we know that they're really high, but behind those stats are real people. And over the last 8 years, I have played many roles in mental health as a patient partner, researcher, peer mentor, mental health first aid facilitator, speaker, and advocate. The common theme in all of my work is centering and making space for people with lived and living experience.
Thank you, Anita. Thank you for being so vulnerable and sharing that. So, maybe Cheryl, we can go to you next.
Thank you. First of all, hello, Tansy, bonjour, and hi to all of those that are listening. The how I was drawn into this work is a bit of a wraparound story. I grew up in a farming community in central Alberta, and with that, it was figuring out what I wanted to do after school. Growing up in a farming family, very pragmatic, and so in central Alberta, there's a large provincial mental hospital, Alberta Hospital Pinoka,
Hmm.
and with that, that was the tuition was reasonable, and my dad actually gave me some guidance around nursing will be a good part-time job for you while you figure out what you're doing. So, I'm not sure if I'm still figuring out what I'm doing or not, but this that psychiatric nursing program opened my eyes to things that I had not thought about before, and it raised questions, and as I started to reflect, I've got a family that has got sporadic mental illness. Well, it's all over really, but nobody wants to talk about it, and so our family isn't any different than most. Um, and so with that, now I'm very focused on how do we build connections? How do we build hope? How do we how do we encourage the spiritual well-being? And so I'm drawn because there's hope in this work, and I am looking forward to when we can actually start to talk about suicide.
Thank you, Cheryl. And Allison, I'll turn the microphone over to you next.
Sure. And thank you, Anita and Cheryl. Like, those are such heartfelt responses. And it is really interesting how our personal experiences draw us into a professional sphere. And I think that's also how we can do really heartfelt work. So that resonates with me. I was always the listener in my family. And as you said, Cheryl, every family has its share of mental distress. And I was always the listener, and I just kept right on going as the listener. I spent the first part of my career working in rural and underserved communities and Indigenous communities in Ontario and Nunavut, and really saw both the need in terms of suicide prevention, but also the opportunities and just the wonderful strengths and resources that communities can bring in terms of life promotion. And as a psychiatrist, that really had not been part of my formal training. I was supposed to sit in a clinic and see people who were in distress and identify risk. But that was at odds with what I was experiencing in the community as the potential. So I feel with 988, the suicide crisis helpline that we now have nationally, that is a sweet spot for me, that I have found, of having a community oriented focus. Yes, being there for people when they're in distress, but also recognizing the strengths that people bring and the need for us to knit all of these services and approaches together to create a whole net of support and well-being for people.
Thank you, Allison. Inspiring, each and every one of you, and your contributions to this topic, and helping us to move forward with this. So Cheryl, maybe I can start maybe the next part of the discussion here about, we're having this conversation, but it sort of begs the question, why are we still having this conversation? What is the issue here that we're trying to improve?
That's a really good question, Dale. Suicide has been a part of humanity since we started. And so the stigma and discrimination that happens with people who think of suicide or have died by suicide leaves a continuing legacy. Looking back at suicide, we talk about historical trauma.
Hmm.
Suicide also provides a base for historical trauma to start, and the pain that happens within families. Suicide isn't going away. Suicide is actually increasing. Every day, 13 people, at least 13 people die from suicide.
Wow.
And as we think about suicide, oftentimes we think about suicide as, maybe it's a person in their 20s or 30s. That's not suicide. They may die by suicide, but suicide happens with young people. And when I say young people, I mean little people in elementary school, in high school, in university. Grandmas, grandpas, kokums, mushums, they also have died by suicide. So for me, we need to talk about this to increase our own level of comfort in saying, how are you doing? Are you thinking about suicide and being comfortable with that? And yet also being comfortable enough to know what to do if someone says yes.
Thank you, Cheryl. So, Allison, as a clinician yourself, again, sort of providing that sort of experience that maybe some of our listeners can relate to, I'm guessing that one of the barriers that limits clinicians talking about suicide is their own fear. Um, uh, so I'm wondering, from your own perspective, can you comment on that? And if you like, do you agree? And if so, how does that fear show up, and how does it present itself in terms of the work that people are doing or avoiding, or how does that just, your perspective?
Yeah, it's really, and I think in terms of being a health provider, I'm a psychiatrist, but I think this applies across different health professions. I think there is a real fear. So the first thing I would want to say is to underscore how important it is, especially for health providers, to be talking about this and to also recognize that as a necessary skill.
Hmm.
We can all confront our fear of difficult things, but as health professionals, I would increasingly like to see this as a recognized and necessary competency that all health professionals have, and that we have to give them the training and the support to do that hard work, but it is essential. We can't avoid it just because it's difficult. And we know that for the majority of people who die by suicide, their last professional contact was with a primary care provider. So,
Hmm.
not a psychiatrist, not someone specialized necessarily in mental health. So, again, we need all health professionals to have that skill set. And I think it's also colored by stigma. it's a sign of the vestiges of stigma throughout society that we are uncomfortable talking about suicide, that we're also worried that we're going to make something worse, and that there's a discomfort there. So I think confronting, we talk a lot about unconscious bias in healthcare now. This is an unconscious bias that's tainted by the stigma around suicide. So I guess how would I finish that? Training is really important. This course about talking about suicide is a really great place to start, and there are other resources. And also, supervision, I think, is really important because it is tough work.
Hmm.
And when we ask those questions, we invite those conversations, we are then a witness to people suffering and to their pain. And that is can be difficult. So it's not just about having the knowledge, it's about having peers to connect with, colleagues to connect with, and ongoing supervision to make sure that we can stay well also as health providers.
So yeah, and I think you've raised an important, I guess, part of the conversation, which is, that I guess it's something that is not implicitly part of the education of many health professionals. It's assumed, or people don't want to talk about it in terms of their own formal education or the way that they are mentored as they enter into the different health professions or health organizations.
I think I see it changing. I definitely see a shift in this course. This conversation is a sign of that. But yeah, I think it does need to be embedded.
Okay.
I completely agree with you, Allison. It needs to be embedded into our entry to practice programs. And those entry to practice programs, whether it's med school, nursing school, paramedics, LPNs, lab tech, the whole gamut. Suicide assessment isn't about doing a risk scale. It's okay, so here's the questions. I need to ask you 10 questions, and please don't interrupt me until I've asked all 10.
Hmm.
It is about the conversation starts with hello. We need to see the other person. And that piece, it is teachable, but we have to recognize the importance.
Thank you, Cheryl. And very grounding place to start, I think, as you say. So from your perspective, Anita, as a certainly as a person with lived and living experience in this space, I mean, how can you describe, I guess, the importance of your participation in helping health professionals engage in this topic?
Yeah, it seems so simple. I often say that including people with lived and living experience in mental health services, programs, and projects leads to better health outcomes. People with lived and living experience have that insider view of suicide, and we understand the nuances of these situations that we encounter. And those are not things you can learn from a textbook. And I often say to physicians, nurses, researchers, and others that those people that I work with, that if you don't know the answer to something, ask the person who is most affected by the answer. Ask them. And in all of my experiences engaging and convening people with lived and living experience, I am I'm always in awe and astounded by the insights and wisdom that happens with those conversations. I will say sometimes engagements with professionals, especially when sharing stories on sensitive topics like suicide, it can feel like a spectator sport. Everyone watching you in the room, trying to get this information because, as Cheryl and Allison mentioned, that there is no real proper curriculum in school for this. So sometimes it can feel like everybody's just sort of watching you. And I use the term trauma porn sometimes because taking in all these details, but engaging people with lived experience and living experience of suicide, or more generally even, takes thoughtfulness and effort. It's important to create safer spaces. And you may notice I said safer and not safe, since you can't anticipate every situation. But
Hmm.
what you can do is your best to ensure the comfort level and level the power dynamics. And I hate to say this, but it has to be said, greeting people with respect and compassion.
Thanks, Anita. And thank you for lending your voice to that and helping us, I think, to understand that from the perspective of those that are receiving care. But, maybe it's sort of a second part, and I think, building on, your answer around, there's that there's maybe not you can't create safety, but you can create safer environment. So, I was going to ask, is there a right way to do this? But maybe is there a righter way to do this, or a better way to do this? Tips and strategies about how to have those conversations, create safer and more respectful environments that do perhaps inspire hope.
Absolutely. I think it's important to flip those stigmatizing attitudes that we know are out there. Things like seeing people as weak, and instead envision the person as an individual with innate gifts, strengths, and the ability to recover. I firmly believe in the principles of trauma informed care, that
Hmm.
when I say that, I'm saying that you are seeing the person, you are hearing the person, you are valuing them and holding them in high regard. And this comes down to meeting people where they are at, showing respect, allowing time and space for the person to speak, and allowing them to share whatever they want to share. So this goes back to Cheryl, you talking about that checklist and the agenda of trying to get through those 10 questions. Don't make it about the checklist. Make it about having a conversation. Be open to listening. Um, also considering what are they sharing, and what is related to the social determinants of health. What types of support would be most helpful for this person at that time? And also ask them what they feel they need to support themselves in their recovery and in their wellness. Use active listening and show you understand what you were hearing by nodding and reflecting back what you hear. It's about showing genuine compassion and empathy and letting the person know you are there to support them. This may be the first time that the person in front of you feels seen, heard, valued, or held in high regard. And although you likely will not know the full impact of your interaction, you may just be that person who represents a turning point for that person. That person with lived and living experience 5 years down the road may remember you for the care and the thought and the compassion you showed. That could be a turning point for someone. And the ripple effect of your actions, um, you might not always know, but it could have a significant impact. So ensuring you are prepared to listen and have conversations with the person with lived and living experience is critical. And asking direct questions. I think we shy away from asking, how are you feeling in this moment? Are you having suicidal thoughts? Or if it's an attempt, how are you feeling in this moment? Do you want to reflect on your suicide attempt? Being direct, but also allowing them to direct the conversation for what is most important for them.
Thanks, Anita. Um, and I guess I'm curious, and I'll just ask Cheryl and Allison both to sort of add any comments to this if they want. But um, you know, I guess my mind is going to what you're also not saying, I guess. And the question is what is a clinician not doing? As an example, so you've talked about empathy and compassion, but I'm not hearing judgment. But maybe in terms of your own reflection, Cheryl and Allison, if there's anything that you would add to that about how does this maybe sometimes show up inappropriately.
Cheryl alluded to this, and it's something that I notice, which is that clinicians, we're in a very medical legal kind of environment where people assume a lot of risk and are held accountable for risk. And so there's this overemphasis on risk and on, making sure you've asked the right questions. And sometimes the connection, the compassion gets lost in that process. I don't think intentionally, but I just think it gets eclipsed by the focus on safety. So I think we have to empower clinicians to have conversations that aren't so focused on risk, because also we're very poor we can identify the risks, but doing so does not really help us to know who's at more or less risk. Like, it doesn't predict the outcome. So whereas connection does, if people feel that they've been connected with, that does more than just putting all the risks down on paper.
Thanks, Allison.
Absolutely, Allison, completely agree with you. Practicing without judgment sounds easy, it's hard. Being able to park our own values and our own experiences, whether our experiences have been with a family member that died by suicide, or a family member that is struggling with PTSD or psychotic symptoms. Listening without judgment takes a lot of practice. And Allison, as you were saying, that's where I think supervision comes in. That the supervision helps you see some of your blind spots, and it helps us. Well, I'll speak for me. Supervision helped me actually see the person that I was with, whether I was in their home, whether I was in the hospital, or whether I was in a clinic. Being able to see the person within their context. Anita talked about the social determinants of health. Being able to understand what those are and the impact that it has on somebody's life is absolutely critical.
Thank you. Thank you both for sharing the more context to that. So building, I guess, on context, Allison, how does the broader context, I guess, in terms of context, shape or need to shape, I guess, how these conversations are happening?
And maybe I'll take that from the point of view of within a healthcare setting, specifically. And I think the most important thing as individual healthcare providers is that we do reflect on our own experiences and our own beliefs, and then critically think about how those might be impacting our work in this area, how they might impact, for one person, it might be that they've had a loss due to suicide, and so they avoid because it's painful. For someone else, it could be that they have a negative judgment, and so they avoid it because it's uncomfortable. So to really understand what we each bring to the table, I think is really important context, and then helps us reflect on the context. Then I think about the healthcare context itself. It's fine to say that health providers should do A, B, and C, and D, but it's actually their organizations that also need to support them to do this work and make it a priority, make it visible in the organization, to have a commitment to suicide prevention and life promotion. We also, for maybe not healthcare providers, but more the general public, I of course think about 988. So health providers can use 988 as a resource. It's a quick 3-digit access to support if there is a suicide related crisis, or people are worried about either about themselves or someone else. Health providers can also refer people to the 988 service. And this year, we're really focusing in on this idea of just in case. knowing that these conversations can come up when we're least expecting it.
Hmm.
So to know that number, to save it, to share it with other people, it's one resource, but it's an important one. If you need to have a conversation and you need support to have the conversation, there's always that resource.
Great advice. Thank you. Um, sort of, so you've talked about, I guess, context from the perspective of different organizations. So what about from the perspective of like populations? We live in a very large country. It's diverse in terms of our geography. Different population types in terms of their demographics and in general. How does that change how, I guess, a health professional shows up?
Yeah, and I think each Anita and Cheryl have also both said things that apply to this. I It's important to take each person as an individual, I
Mm-hmm.
think, and recognize that our identities are intersecting. We all come from different racial backgrounds, gender backgrounds, sexual backgrounds, geographic backgrounds, and so it's important to understand that we're all have those intersections, and it is, I think, critical to recognize that some groups have been more disadvantaged socially, economically, historically, and that there are higher rates of suicide amongst some groups. So we need to hold that, and we need to, not everyone from each individual from those groups, we can't think of people as being at risk,
Yes.
but it's more about providing resources to groups where there is a disadvantage, and fixing those social determinants of health that both Anita and Cheryl talked about. So it is a bit of a balancing act, treating people as individuals and recognizing that some groups do have more adversity, face more adversity, have more exposure to suicide, for example.
Allison, great points. One of the pieces in identifying particular groups that are at higher risk, absolutely linked into social determinants of health and what supports are there. How have these individuals or these populations been nurtured along? What opportunities have they been given to thrive? And when I say given, I mean things like, do you have groceries? Do you have a blanket to cover yourself up with? When we think about the different groups and the general suicide risk within groups, we can think about it in much the same way as cancer.
Mm-hmm.
So you've got people that are the blonde, fair-haired, you got to use your sunscreen. And so there are health promotion activities for a whole variety of symptoms. So whether it's cancer, whether it's suicidal ideation, whether it's constipation, there are health promotion activities that can help support individuals, but organizations need to be vested in, and not automatically, it's like, oh, well, you're from this group, so you must be suicidal, or if you're not suicidal, you will be suicidal, and then move on to the next. It's We need to really be open and to talk about suicide, and talk about suicide and its treatment within the context of racism and discrimination.
Yeah, I think that's great advice, Cheryl. And we've had another podcast on a tangential topic around stigma, right? I think it was a really important conversation around how people check their assumptions and biases, right? But I think there's I think that delicate dance, I think, as you're sort of describing, right, about using that information to help, but not to assume, perhaps, in terms of how you show up, but also perhaps, drawing on my own, literary background, Allison, right, as readers, right, we have to understand our biases, right, when we're, approaching any kind of context, and how that may, change the way we're reading or seeing. And I assume that's a really important part of what we're discussing here as well.
Yeah, I think literature can give us many skills. I was surprised to find that made its way into my bio, but indeed, I think the arts can really, um, show us different ways of relating to each other and help us be alert to the themes in our own lives.
Thank you. So maybe a question for both you, Anita and Cheryl, as a sort of a next part. So I'm sure that one of the things that is under that iceberg that we've been talking about is that many clinicians have their own lived experiences and stories that they're bringing to this, right? So part of the assumptions, part yes, but they have their own experiences with suicide. Um, uh, Personally, through their families, their communities, their social circles. So, is it appropriate to draw on that information? And if so, how does that show up in terms of the way that they're providing care? Um, so, I think it's over to you, Anita, first.
Thank you. Yeah, so this is one of those tricky questions, and I'm going to relate it to my own experience because it took me a long time to be vulnerable and have the courage to speak about my mental health struggles publicly. I'm talking decades upon decades, but I'm not going to give away my age when I say that. But I also knew once I said it out loud in a public forum, there's no going back. I broke through that barrier with a co-op radio interview in 2018. And then a little bit later that year, I did a storytelling event. And it started off with I wanted to die. I had a plan and I was ready to carry it out. And then the next year, I turned that into a solo performance piece where the opening scene was the setting of my suicide attempt. And if I Google, I like to Google myself ever so often. And yes, I've been public and it's out there. And in my work, I've had many opportunities to work with all types of mental health leaders and providers, and also participate in interview panels for leadership positions. And I like to ask everyone why they do this work. And I ask this just to find out how vulnerable they are willing to be. I also recognize that not everybody is comfortable with this, but I feel like it's that question where I see on their face, it's not even what people are saying and sharing or not sharing. It's also their face because it shows emotion, it shows connection, it shows compassion. And I feel that it's important. And I know this is might not be a popular opinion, but the provider and patient relationship, by having shared vulnerability, it levels those power dynamics. It is no
Hmm.
longer practitioner and patient. It is now person to person connection. And this connection establishes trust, and it also allows the person with lived and living experience to know that even if the mental health circumstances are different, the deeper understanding of being affected by mental health issues, it deepens the conversation and it deepens the trust. So for practitioners to reveal, it helps me personally when I've had been in this situation to understand that they are supporting me beyond the textbooks and the clinical setting. It brings the humanity back into the interactions.
Thanks, Anita.
Yeah, I absolutely agree with you. The thinking back to one of the nursing classes I was teaching and a student I had worked with, we started to look at self-disclosure. And it came up as an issue or topic for discussion because in a clinical setting, this student was reprimanded for um, disclosing that her family had some pretty significant physical disabilities within it. And so this person of course, got hammered on her clinical evaluation. So what did we do? We decided to do a research project. And let's talk about how much self-disclosure is too much. And so as we worked through that, the self-disclosure needs to be just enough, or could be just enough, so that people don't feel like they're alone. It's a way to provide connection. But as you're sharing your personal story, and I know I don't share my personal story too often, um, because there is still so much stigma and discrimination that happens. But as we share it, one of the critical as we share our own experiences, one of the critical features is to share with humility. You're sharing for a connection. You're not sharing because you're the expert. You're not, or I'm not, for sure. So the self-disclosure, I don't think healthcare professionals have really got our heads wrapped around that very, very well, because boundaries, boundaries, boundaries. Those boundaries are walls. Those boundaries could be bridges.
Mm-hmm. Yeah, well said, Cheryl. Thank you.
Can I
Yeah,
can I
yeah.
just add very quickly that I think that is such a good point, about the boundaries, and I know that practitioners are told, like, you have to be professional, you have to keep this emotional distance piece, and there's also pressure from the workplace as well, because what are the implications about sharing your lived and living experience within your work environment as is another factor that comes into play. But we have to find ways to make it easier that these conversations can happen, because ultimately, if the focus is the person with lived experience and helping them find a path for recovery and to live a full life, then this has to happen.
Thank
Thank
you
you.
both. Yeah, yeah. And very complementary sort of perspectives. Yes, Allison, I think you want to add something.
Yeah, I mean, I love this is such an important part of the conversation about let's talk about suicide, because I think it does raise the question of how much of your own personal experience should come into it. And I agree with everything that's been said so far, and just want to make the point about I think this is another clinical skill. It's to help people to understand when is the self-disclosure in service of what that other person needs, especially if they're in distress, and how to safely share.
Mm-hmm.
Because no, we wouldn't want to censor anyone, but people also need to appreciate there is evidence that sharing certain details can be harmful and can in fact lead to exposing other people to experiences that actually increase risk. So I think it's nuanced, and it's another set of clinical skills and of supervision, um, and also the lived experience role. I think it's incredible. I've seen in my within my own career such a growth in that area of having lived experience engagement. It's absolutely essential, and it's also a role because we all have lived experience. So
Mm-hmm.
I think it's really important for teams to know when someone is coming to join an engagement, whether it's a committee or an educational event, as a lived experience advisor, that is a particular role. It doesn't mean, oh, we all necessarily need to be acting in that role, because sometimes I'm acting as a psychiatrist, and sometimes I could opt to act as in the role of bringing lived experience to the table. It's hard to occupy multiple roles at the same time in a meaningful way. So I think it's an area where that our field is really developing in.
Yeah, I'm sure, right? Because I think to build on your metaphor, Cheryl, right, about the walls. I mean, who are they there to protect, right? Are they there to protect the clinician? Are they there to protect, right, the person receiving care? And then, yeah, I think like anything, I mean, asking permission perhaps to share or to ask, probably is a way to navigate those moments. But yeah, I think it probably is very tricky in terms of where do you, how far do you go before you start co-opting the experience as your own, and creating other challenges. So, but thank you for weeding into this with us. Um, so maybe next, in terms of Allison and Nita, maybe your advice to healthcare leaders in this space. Not to say that clinicians aren't leaders themselves, but those that certainly have a leadership role within a healthcare organization. How can they foster the conditions for these conversations? How do they create safe spaces or safer spaces? Anything else they should be doing in your experience? So I'll start with you, Allison.
Sure. Well, I mean, everyone loves a good accreditation conversation. So fun. But I will say, like, when I think at the organizational level, making a commitment, making a public, clear commitment to contribute to suicide prevention and life promotion is a place to start. And there are, so through Health Services Organization and Accreditation Canada, there is a standard. There is a suicide prevention program standard that I think can give organizations a place to start.
Great. And Anita?
Thank you. And just following up on what Allison said, I think this is a piece that's really important, is thinking about putting this in strategic plans, making organizations accountable to this around suicide promotion and suicide prevention, being able to provide education and also pairing it. So we know there's lots of facts, but pairing it with stories, and not to tell a story so you can just say I was paired with this and I told my story, not to hear, oh, that's so sad, look at you now. That's not the purpose of the story. The purpose of the story is to listen to it, see the facts, listen to the story. Hopefully it makes you feel something, but ultimately, what are you going to do differently based on that education, right? This is a really important piece. I also think that it is really important to think about um, our global stage here. People in other countries, what are they doing for mental health? What are they doing for suicide prevention and promotion initiatives that are working well, things that are evidence-based? We don't always need to recreate the wheel, because, it can be a hamster wheel. At some point, we need to look to what other people have done that has worked successfully and then bring it in and implement it within our context. And that takes the leadership to really go into these spaces and make some bold decisions. And it also has to reflect people that are working on the front lines with people with lived and living experience, that have had experiences of suicide attempts or ideation. So I feel like our system is still so fragmented that leadership at that organizational level doesn't still have a good sense of what is happening on the ground. So I think that is important to change so that we can start moving forward.
Thanks, Anita, and thank you for raising the importance of education and training. I mean, it's better that it comes from other people than me, because obviously I sound as a person who's overly committed to it, given my own professional background. But I think education is certainly a critical element to that, and I do believe the course that we've partnered with developing with the Mental Health Commission of Canada is a critical part of that. And we've been approached by health leaders of organizations who are saying, how can I use this to educate all of my staff, or certain segments of their organization, to prepare them to be better prepared. So I think that leaders can certainly take a role in that basis, if nothing else. So maybe over to you, Cheryl, as we come to an end, or close to an end of this conversation. Is there anything else that you think that needs to change, within healthcare, within systems, to, to make a real difference on this topic? You spent a large part of your career in this area, so what would be your advice to us?
There the there are a whole bunch of little snippets of advice. Mm, However, the one that I think is important is I've grown up in a healthcare system that tolerates stigma, discrimination, and quite frankly, tolerates abuse.
Mm-hmm.
So as we are moving forward, there are lots of good stories that are told around anti-racism, indigenization. However, those are still inspiration or aspirational.
Mm-hmm.
And so we really need to start taking some action. And that action is going to be disruptive. It is going to be disruptive to systems where people are supposed to fit into slots, round holes, round shapes, square holes, square shape. As we start to understand suicide, and suicide is a symptom, suicide isn't the disease, it's the symptom. And so as we are looking at this symptom and how do we actually understand it, we have to be able to talk about it. And so I know when I first started, I would say a little prayer. Okay, I'm going to do a suicide assessment. Please let them be okay. So, in doing that, we need to be comfortable with how do we establish connection with people that feel they don't have a place of belonging anymore, that there isn't hope, that's seeing a future isn't comforting. So I think we really need to start with some of the systemic racism and discrimination. We need that. And as we are trying to move forward, the actions often have been punitive.
Mm-hmm.
Well, we're going to correct it, so you're gone, you're gone, you're gone. All that does, or all that has done in my eyes, is that it has pushed the stigma and discrimination underwater. And with that, it makes it even more challenging to start to talk about it and to start to break down the barriers on being with someone that is in distress.
Thanks, Cheryl. And I guess part of, and I'll just sort of toss it out there for anybody who wants to comment on it. But based on one of the points you just made, I guess maybe comments on the importance of a just culture, right, or creating cultures of psychological safety, broadly speaking, within an organizational culture, and how they play to some of what we're talking about, or creating the conditions for that.
Big concept. And I wonder if all organizations see themselves as playing a role in that. I mean, they should, and they do, even if they're not declaring it. All organizations are playing a role in whether a culture is just or not. Um, but not everyone aligns themselves with that idea. It's a provocative idea. It, to me, within suicide prevention, it really fits with that understanding that suicide prevention has to be a whole of society approach. We
Mm-hmm.
need everyone, like every organization, every person needs to contribute to those efforts.
Yeah, I completely agree. This is a complete shift It's a shift in our society, it's a shift in our health system, it's a shift in attitudes, also thinking about the shift of how suicide is depicted and the language used in media as well. So it is disruptive, but we need to do something different for sure.
Thank you. So my apologies for if I was too provocative, but you provoked me in terms of my thinking. So thank you for bearing with me with that. So any final words to each of you as we come to a close in terms of this? Anything that we haven't talked about that you think we should talk about, or your parting words of advice to our listeners? So I will start in reverse order. Maybe start with you, Allison.
No, just thank you for this conversation, to all three of you. It's been provocative in the best way. I am always aware when we're having these important conversations. We know suicide related thinking is extremely common. So, any of us, any of the listeners may be struggling right now or may have struggled in their own lives with these kinds of thoughts. And so, I always just want to say to people, if you are struggling, to reach out, to seek support, and to keep asking until you receive the right kind of support, because everyone is deserving of that connection and that support.
Thank you, Allison. Cheryl.
This has been a great conversation, and I absolutely appreciate the opportunity to sit down with Anita and Allison and yourself, Dale. This has been great, and I look forward to our next podcast of What If They Say Yes?
Yes, that would be a great
Right?
podcast.
What if
Thank
they
you.
say yes?
Yes.
And so with that, I just wanted to say thank you and miigwech, and I hope that you all have a great day.
Thank you, Cheryl. And final words to you, Anita, please.
Thank you, Dale. Big thank you to you, Dale, for bringing us together, and Jennifer as well, and Allison, Cheryl. It's been so wonderful to have this conversation with alongside of you, and I know I've learned so much in the past hour, and just so appreciate all the insights and everything that was brought to the surface. And I want to recognize that there are many pressures on the mental health care system, policies, procedures, processes that keep things so restrictive, and those things that are being told that they need to be followed. But please don't forget the humanity, the person with lived and living experience. Really see, listen, value, and hold in high regard every single person in your care. And if you are someone that is struggling, please don't give up. These are words that were told to me. And sometimes it's hard to see through all the darkness, but keep going, because you don't know how your life will unfold. And you might miss the best years, moments, and experiences of joy and happiness in your life.
Thank you, Anita. So thank you, each of you. If nothing else, I think we've talked about the importance of conversation when it comes to talking about this very difficult topic, and the power of creating humanity through conversation. And so many thanks for all of you sharing your wisdom, your experience. Many thanks to the Mental Health Commission and Jennifer Jeffrey, the Jennifer that you've referenced, Anita, for their support in bringing this together, and their partnership in helping to build a course, which again is free to all. And so I hope people are able to take advantage of that and use the conversations here today, which are just the beginning and certainly not an end to this conversation. So thank you, and look forward to talking to you again.
Thank you.
Thank you.
Bye now.
You've been listening to the HQ, and I'm Dale Sherback, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.